Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon and welcome to VITALS, brought to you by Northeast Ohio Medical University in collaboration with University Hospitals of Cleveland. VITALS is an open forum venue to discuss our nation's biggest healthcare issues and hear from transformational leaders who are using the VITALS tools: value, innovation, technology, advocacy, and service to help solve those problems. I'm really proud to hear from today's transformational leader, Mr. Scott Becker. Scott is the founder and publisher of Becker's Healthcare, a leading source of business news, analysis, and guidance related to the healthcare industry. Mr. Becker is a distinguished entrepreneur, investor, and legal professional who has built a remarkable career at the intersection of healthcare, media, and law. His expertise spans across various industries, including healthcare, private equity, and venture capital, where he has made significant investments and contributions as an active investor. He uses his extensive experience to help others navigate the complexities of building and scaling successful ventures. Mr. Becker graduated from Harvard Law School, where he obtained his JD. At Harvard, he was a moot court advisor and had the privilege of teaching and advising future President Barack Obama. He is the author of several books and the host of 2 highly ranked podcasts, and has interviewed prominent figures to include George and Laura Bush, Bill and Hillary Clinton, Nikki Haley, and Michael Strahan through Becker's Healthcare conferences. Please join me in welcoming Scott Becker.
Yeah, a pleasure to be here, and hopefully people can see me okay and hear me okay. The most important person I've interviewed is yourself on our podcast. I am thankful to speak to both these 2 combined institutions, Northeast Ohio University, Medical University, University Hospitals, 2 great institutions solving one of the core problems we have in healthcare. I'll talk for about 15, 20 minutes. I'll walk through 5 to 7 overriding issues, and then 5 to 7 issues that were talked about on our healthcare CEO advisory call just a couple days ago. And I'll start with something that's talked about in the opening slide introduction, the video, which is beautifully done. Healthcare has a daunting and growing supply and demand problem, i.e., we've got a growing population, 340 million people. I don't even know if we could count anymore, and not enough doctors, nurses, allied healthcare providers, technicians, everything. We have just very clearly a supply, demand, and math problem, just short across the board in so many situations. I talk often, I'll use doctors as a metaphor for all of it. We've got 1,060,000 physicians and 330 to 350 million people. The numbers just don't really work. We're hyper short primary care and specialist. It's very popular to really focus on just primary care, but just as important to think about specialists. Many areas in the country, there's almost deserts of specialists, many places closing down labor and delivery because they just can't staff it. There's an area in Minnesota, for example, one dermatologist for 500,000 people. Similarly in Texas, with the growing advent of all kinds of Alzheimer's illnesses, just not enough neurologists, dementia for the amount of people, same concept. One neurologist for 500 to 7,000 people. More and more in healthcare, you need to know someone to get care. So this daunting supply and demand problem has huge impacts on health equity as well. You see in many communities, there's the incredible growth of concierge services. And I don't blame any physician for going concierge, but it points to the lack of supply and demand that we have, and also puts us in a spot where people that need care as much as anybody certainly can't afford the concierge cost. I saw one stat on your opening slide. The stat I've heard more recently is we need about 200,000 more primary care physicians, but we only produce about 25,000 primary care physicians a year. And increasingly, doctors go part-time by the time they're 40 or 50. And so we've got a situation where just from a math problem perspective, we're in horrible, horrible shape. I will tell you, and I don't mean this as a negative about Neomed or about university hospitals, medical school plus residency was largely the whole curriculum and how we teach students and develop doctors and nurses and other providers was built largely prior to the internet. And so we've got great education, but it often takes too long. It's done in a shorter period of time in other countries where they produce great doctors, and we're often the beneficiary of that in this country. So somehow or another, we've got to shorten the combined medical education and residency. It's become a 10-year process. And so often doctors are part-time by 40 plus, so not out of school till 32 or so, part-time by 40, and it just doesn't work math-wise in terms of taking care of our population. The other thing I'll mention on supply and demand is coverage is very, very different than access. I'm a big believer, whether in the Affordable Care Act or not specifically, I'm a huge believer that everybody should have coverage. I think more and more people, whether on the right or left, have gotten to that spot where they believe everybody should have coverage, but that's very different than access. We could all have coverage, but if we don't have doctors, nurses, providers, technicians, we won't have access. And access is very different than coverage. Politicians, the second point I'll make is politicians, I see very focused often on talking about some of the bigger picture issues, but they're very bad at focusing on real problem solving. I think many of the politicians are shielded from many of the access problems. They have the care they need, whether it's specialist or primary care, in a way that the rest of us don't. All of us that are on this call are involved in healthcare somewhere or not. We probably have some advantage in accessing the system, but we know how we need that advantage and how difficult it is, even with knowing people, to have the access we need. Politicians talk about all kinds of things, but they often don't talk about the real issue. How to create more residency spots? How do we make medical education and fix supply and demand issues? They're so busy politicking that they're not problem solving. The third thing I'll talk about, and I'll try and slow down just one bit so that I'm not giving people a headache or putting them to sleep. But people talk about technology as a panacea or a solve for everything. The reality is, I am certain that the reality of the problem solving is somewhere in between. It's both people and technology. It's not one or the other. Technology is often an incremental game changer and can leverage people better, but it doesn't yet alleviate the need for more doctors and providers. The technology improvements are critical and they're often incremental, but they in and of themselves won't solve our problems in healthcare. We view them as it's both, it's technology and people. The fourth thing I'll talk about for a moment, and this is often an unpopular topic, but changing the payment system doesn't cure the core supply and demand problem. It's very easy. You got people on every side of the equation yelling about the payment system. My belief that it's much more is a supply and demand problem, and that under either system that you have, whether it's completely quote unquote value-based or completely fee-for-service, you have an outlier of misbehavior, but that's not the core problem. Certainly under fee-for-service, you got some percentage of physicians and parties that abuse the system, but probably nothing was more abusive than insurers reporting insane profits during COVID for all the wrong reasons. They were reporting great profits, not because they were doing something right, but because procedures weren't getting done. Anybody that's living currently as a health system through the extent of pre-authorization and challenges getting paid knows that the value-based value-based means a million different things to different people, but capitation and insurer control of healthcare is certainly not the answer any more than pure fee-for-service is the answer, and there's plenty of abuses on both sides. During COVID, medical loss ratios for insurers went down significantly, so they made a lot of money and got very excited about it, but certainly didn't mean we were getting better care. It meant procedures weren't getting done. The fifth point I'll make is that the payers in general have immensely more power than do the providers. 4 of the payers are in the largest 20 companies in the United States by revenues. 2 are in the top 6. The power difference between the huge payers and the providers is just a massive, massive problem. If you went back years and years ago, many states had 5 or 6 core commercial payers, and none of them were dominant. Now, in almost any state that you're in, there's one dominant payer, there's a second important payer, and the rest pale in comparison. And what this means for providers is you have no power in negotiating with those payers because they really are the dominant payer in your state. The thing that I'll note when I talk about this, the 2 largest companies in the country by revenues are Walmart and Amazon, but then you end up in the top 6 are United and CVS as well, and Cigna and Elevance are also of the top 20 companies by total revenues in our nation. So there's just a massive power difference between payers and providers. The sixth thing I'll note, and I'll get to some of our comments from our CEO call, is Medicare and Medicaid are now more than 50% of healthcare. So people used to be in a spot where they could offset some of their, governmental pay with better paying commercial payers. Now, 2 things have happened. The commercial payers aren't as generous as they were at one time in terms of paying more than Medicare and Medicaid. And second, many systems report that 60% plus, and in some areas more than that, are Medicare and Medicaid revenues. The 7th point I'll make is Medicare Advantage. Medicare Advantage is a fascinating example of lobbying gone amok. President Trump, and this is not a knock on President Trump or Biden, just bear with me for a second. President Trump came into office very pro Medicare Advantage. Medicare Advantage is now more than half of Medicare. So far, it has massive challenges in terms of performance so far. Hospitals are leaving Medicare Advantage where they can. Pre-authorization and denials are running rampant. One of the things that happened with Medicare Advantage, President Biden came into office against Medicare Advantage, and this is where I'll make sure that I'm bipartisan. He then had enough discussions with the insurance lobby, which is one of the most powerful lobbies we have, and turned around and became very pro Medicare Advantage. You ended up with both presidents, President Biden's administration, President Trump's administration being pro Medicare Advantage. It's been a bit of a political football. The insurance companies are very, very powerful. From all I could tell, Medicare Advantage has led to more cost for the government. It's led to very indifferent results for patients. It's probably led to more problems for hospitals and health systems. And what it has done, it's added a massive administrative layer on top of the Medicare system that for most seniors worked pretty well. And so it's been a bit of a debacle. And again, it's not that there weren't good ideas behind Medicare Advantage, but from my perspective, all it's done is added another administrative lever that has not been really helpful. So those are at least a starting point of 7 of the overriding issues we talk about. I'll go through 5 or 6. Some of these are overlapping from our call with our health system CEOs. Insulin and IV fluid shortages are reminding people of the supply chain problems that we had during COVID. Obviously, we can't have a call today and discuss the challenges that are happening in Florida with the hurricanes and so forth. So that's its own huge challenge currently in another emergency. On our CEO call, we talked about the increased reliance, which I've touched on, of government pay. Also, we talked about the power of the payers and Medicare Advantage. Another issue we hear about often from our leadership, from different leaders in the country, is hospitals are stacked and there's not enough capacity, partly because nursing homes have come under horrible economic problems and there's no place to discharge patients to. So ERs and hospitals are really stacked up and in a challenging spot. A few other issues that we talked about the other day, health systems very reliant on a handful of different payment programs, such as 340B and other things. We continue in our country to have tremendous shortages in the behavioral health area. I mean, the ability to see a psychiatrist that has the time to actually talk with the patient, that's almost a lost art, a lost science. And it's quite frankly a shame, but not nearly enough psychiatric and behavioral health professionals. It's another reason why ERs and hospitals are swamped, because there's no place for people to go with mental illness. And we've just got a huge, huge challenge. People on our CEO call also talked about challenges with private equity and certain doctor specialties and feeling as though they're just in challenges in negotiations with them. And again, but this is across the board, whether private equity or not, horrendous shortages of hospitalists, anesthesiologists, radiologists, and a lot more. And it goes back to our supply and demand problem, just really, really challenging throughout the country. Bad now, and again, going to get a lot worse over the next 5 to 7 years. The supply and demand challenges have horrible impacts on health equity. And there's so much that we could talk about. I will do this. I'll finish up. This is our prepared comments. And so many of them come back to the same thing. And I'll tell you this, one of the things people talk about is, well, every once in a while I'll hear somebody say that preventive care could solve everything, or that pharmaceuticals could solve everything. And the thing that I'll tell you is the two largest countries in the world, China and India, and this is not a knock on them, they were required, due to the amount of people they have, 1.5 billion or so, to very much rely on preventive care efforts and not enough doctors and nurses and healthcare professionals to take care of people. The clearest example of trust but verify. Yes, I'm a believer in preventive health. I'm also a believer in, weight loss is a huge positive for a country with a huge obesity epidemic. But this concept that we could rely on that in of itself it is shown to be sort of not feasible or not smart by the experience of China and India during COVID. India during COVID, they just don't have enough doctors and providers for the amount of people they have. So at some point they were completely overrun. China took the other strategy. They don't have enough providers, so they decided that they better keep everybody on lockdown for as long as possible to avoid spread of COVID. And the lesson for us here is, it's yes, prevention, yes, GLP-1s, yes, technology, all those things, but trust but verify. We better make sure we have enough healthcare professionals, physicians, providers, techs, nurses, CRNAs, everything across the board to make sure we could take care of our population, because there are limits to what we could do on the preventive side. I'll wrap up my core comments with that and turn it to Monica and team and thank Dr. Langle and Neomed as well as University Hospitals for having me on today. Thank you very, very much.
Thank you so much, Scott. A lot of insight there. I'm one of many who read Becker's every day and listen to the podcast. And I think it's, wait, we're going to have you come back and turn your video and your mute off. There you go. I want to welcome everyone. I'm Monica Robbins. I'm the senior health correspondent for WKYC, the NBC affiliate up in Cleveland. And I want to welcome all of our dozens of participants in this Zoom webinar. And I hope that if you have any questions for Scott, you will put them in the Q&A right now. We already had a message from Dave who said he's a big fan of Becker's and is very impressed by the work it does. And your point about medical school did strike a nerve with some people. So I want to start off with this question. As you noted, we have a substantial workforce shortage. This has become complicated by clinical turf wars that are playing out in the legislature across all 50 states. Rather than allowing all clinicians Whoops, hold on. Oh, my question disappeared. Oh, here we go. Okay, rather than allowing all clinicians in various fields to work at the top of their licenses, professional lobbying teams representing siloed provider types are working to prevent scope of practice bills that are often created to benefit the patient through access to care. How would you propose we bring these groups together to address our healthcare access to and access challenges?
Yeah, no, I think it's a great question. And letting providers practice at the top of their license. Oh, it's a fascinating question and fascinating issue. The thing that's most fascinating to me about it, the biggest silo out there for a very long time was empty anesthesia versus CRNAs. And what happened with that specialty is hopefully telling for other specialties. At some point, the empty anesthesia world was so against CRNAs until at some point, I don't know if this is an appropriate word to use today still, they cried uncle. They said there's just not enough anesthesiologist coverage out there. So now we welcome CRNAs, and that's sort of where that's moved towards. So the anesthesia lobby was absolutely against it until it just got to the point where we had just daunting shortages. And then at some point, CRNAs and anesthesiologists learned to work with each other. And many states now allow CRNAs to practice without an empty anesthesia by necessity. Very similarly, and CRNAs are critical, and we still don't have enough CRNAs and medical doctors in anesthesia. You have some of that turf war in physician assistants and in primary care, but I don't think that much is much there. I think primary care, we are so short. Everybody knows when you need PAs, and the hope is that PAs with enough intelligence, and they have to be smart, very smart themselves, and enough information tech help, AI help, et cetera, can do so much of what primary care physicians do. I do worry about us moving towards the dental model. One of the beauties of healthcare, Monica, and I'll be quiet in a second, I promise. I won't take every question and take 10 minutes on it. One of the beauties of healthcare is you can't lie to us because every single one of us is consumers. People follow that every single one of us, we're not just involved in the system, we're consumers too, so we see it firsthand. The dental model has become the model that I hope we don't move to. All of us go to the dentist, and anybody that's gone to the dentist, at least my dentist, you see the dentist for 30 seconds, 60 seconds after the dental hygienist. It feels like you see the dentist almost just so the dentist maybe can add a little wisdom, but more so that he or she can make sure that they've checked the box and could bill fully for the visit. I mean, we've moved to this ridiculous situation where you don't really feel like you're seeing a dentist. I don't really care. I don't need to see the dentist any more than I need to, but it does feel like a model that unfortunately it's become almost a gamified model than a caregiving model. And that's not, and we might be moving towards that with so many specialists and PAs, but then we need highly qualified PAs, great allied health practitioners, and we have a ton of them. I mean, you know, at one point, my parents would complain about their seeing a PA. Now everybody expects that we're seeing the PA, and it's okay. And it's largely okay. What I don't like is the dentist coming in for 30 seconds where it feels like that dentist is coming into bill, not because they're adding any value to the supply chain, to the sort of care or clinical chain. I'll be quiet for a minute, but I think, yeah, the turf wars are, you know, they're big. I mean, they're big issues. It's why we have insurance companies running Medicare Advantage and just adding 10% of the cost for what I could tell is zero benefit right now.
Moses wants to know, thank you so much for your presentation. Another major challenge that was magnified during the pandemic is the shortage of medication with so much reliance on supply chains. With challenges on many fronts, how do we begin to fix this problem and what can contribute to a solution?
And this was a question, Monica, did you say from Moses?
Mm-hmm.
Well, if Moses is on, he or she should be able to solve the problem. No, it's I say that facetiously, of course, but thank you. Yeah, no, this is a really challenging problem. And again, we thought it was a COVID emergency. It's an emergency again with IV fluids. You've got many places in the country that are very short on IV fluids because a factory, you know, ran by one of the largest suppliers ended up down. It is very challenging. And you know, we work in a free enterprise world where certain manufacturers manufacture stuff and others don't. I don't think there's a real answer around that because when the government does it themselves, it's almost like the Maginot Line in France. they're fighting the last battle. So they build a plant to solve this problem. They build it inefficiently. I don't think there's a great answer to it. From a health system perspective, it goes back to COVID plan is constantly trying not to be over-reliant on one or two suppliers for whatever you need. I mean, you've had some of the big not-for-profit systems have built their own generic drug company, a fantastic effort to try and lessen some of that reliance on where you're not held hostage. You're just very vulnerable or fragile to a few pharmaceutical manufacturers. I don't think there's a great answer around it. I don't think there's a great government planning answer around it. The best that systems can do is try and make sure that they're not so fragile. We all try to consolidate suppliers, and then we learned you can't consolidate suppliers that much. And we also all tried to be very lean. And one of the things that was learned during COVID is you can't be that lean. You have to have some inventory, some supplies. And it's a constant challenge. And when you look behind the window to am I too reliant on one? So I've gone to 3 different suppliers. What people often find is they've gone to 3 different suppliers, but they're all manufacturing in the same place. So it's a very hard job to try and solve supply chain when it goes badly.
Michael says, thank you for your insights on Medicare Advantage plans. What do you think about the similar trend toward managed care in Medicaid? In Ohio, we're an expansion state and we have many managed care plans. Patients I've spoken with seem to like the choice, but are sometimes unaware of the differences in network and other nuances.
Yeah, I don't have as I've not studied the Medicaid expansion. It's so complicated. At the end of the day, by and large, I'm just thrilled to have people have coverage. In terms of the Medicaid managed care providers and players, it's very similar. There's a handful of big players that really run these for different places, and it's complicated. The idea is that these big players, the Centenes, the Humanas, the other players will be able to manage it better than the state can manage it. In some places it works, in some places just added on another administrative and costly layer. Seniors, this is a challenge for, seniors run from 65 to my parents in their 90s. One of my parents has serious dementia. Having him pick out a Medicare Advantage plan would be ridiculous, and then would have no idea that he's lost access to certain networks and providers. I mean, I think many people, consumers, would say, I liked my Medicare as it was. It worked for us, and I had my choice of where to go. And I'm sort of lost by all this Medicare Advantage stuff, I think, where consumers are moving towards. But, it's challenging.
Your dental example struck a nerve here. So Kelly is a pediatric dentist. She says, I respect and need our dental hygienists. However, they cannot diagnose dental caries or pathology. Although she says, I can clean teeth. My time is better spent diagnosing and treating caries and pathology. And the dental hygienist time is better spent managing your gingival and periodontal health.
We could not agree more with that. We could not agree more with that statement. We could not agree more with that. That's not what I'm saying. What I'm saying is I feel like the dentist, and I apologize to the pediatric dentist who raised the question, is that sometimes I feel like my dentist comes in for 30 seconds. I don't expect my dentist to be cleaning my teeth. Never. I love the dental hygienist. I think the system works. It's an anecdote for the dentist sometimes comes in for 30 seconds, sometimes for 2 minutes. And I understand they've got the high level knowledge to say, is there really a problem here or not? And sometimes I feel like it's really just, it's become a gamified system. I don't think the dentist should be doing the teeth cleaning whatsoever, or scraping my teeth. I do feel like we've set up a billing system that is being worked hard, and it's evident in the 30 or 40 private equity funded dental practice management companies that work this model extremely hard. I mean, the dentist, you might not even recognize the dentist because they're in for 30 seconds. And that's not a knock on that dentist who asked the question. I assume she spends a little more time with her patients. I certainly don't expect her or him to be cleaning teeth, but I do think it's become where the psychiatrist business has become. They don't have time to talk to patients. It just is, it's the leveraging of talent. And it's almost a, harkening back to a bygone era, everybody, like when I was growing up, I knew my dentist. Now, 1 of 4 different dentists comes in, depending which day it is, and they talk for 30 seconds. I don't know who is who really, and nor do I necessarily care that much, but I don't think my dentist should be cleaning teeth. But I do think the 30-second with me is sort of just it's an observation on where the system has gone and where we're going to be going to in all specialties if we don't create more doctors throughout the system.
To your point, I don't think it's just dentists either. I had an appointment this morning that a PA could have handled, but I had to see the doctor. So it happens in several different fields. You know, if there's a problem, that's one thing. So I think we understand what you're saying. Brian says, what can the next president of the United States do to help with the supply chain of providers? Would student loan assistance help making medical education less expensive from the beginning?
Yeah, I mean, student loan helps, medical education helps, but that's not the stopgap on our system. The stopgap in our system right now, at least on the doctor side, is not enough residency spots. In one of the big bills, there was 4,000 residency spots added on. That ended up not getting passed because it was added on to a huge bill. What could be helpful is to recognize here's the core problem we're facing, and not to politicize over it, but to solve the core problem. And the core problem right now is 50,000 people apply to medical school, 20,000 get in a year. We've got more medical schools being built. Our problem is not the number of medical schools or medical school spots. I mean, it's a problem, but the much bigger problem is the amount of residency spots, because medical schools can't let more people in because they don't have any place for those patients to go for residency. So what the next president could do is try and focus on solving the problem and not politicizing everything. I mean, Vice President Harris, President Trump talk so much about the Affordable Care Act. That's already here. That is what it is. It's added a lot for coverage. It's cost a lot of money. There's pluses and minuses to it. But talking about that is like talking about the Maginot Line again, to go back to the France example. Why don't we talk about where's the problem in creating more doctors? When somebody talked about the guild system earlier, the biggest problem with the guild system is requiring this long of medical education, not figuring out a way to do it a little quicker. You know, I'm a lawyer, had to go to law school for 3 years, didn't learn anything in 3 years I couldn't have learned in 2 years. And that's not that we couldn't do med school. Could be 3.5 years versus 4 years, 3 years versus 4 years. I don't know. Residency might be able to be 3.5 years versus 4 years. I don't know. Fellowships as well. I certainly know I learned very little in law school that I use as a practicing lawyer. And that's not to say to make the same knock at medical school, but I know we could do it better than 10 years. You know, 4 years of med school, 4 years of residency, often 2 years of fellowships. I know we could do it quicker than that, but that's a guild school. That's a guild system problem as well. So, but the president could focus on how do we get more residency spots created to start fixing this problem? Right now, our politicians aren't interested in solving problems. They're interested in getting elected. They're two very different things.
Would you call that the biggest issue that needs to be, addressed by Congress, or is there another bigger issue that, politicians can stop politicizing and actually do something about?
I don't know. I think so many of us are faced every single day with the shortage of primary care, shortage of specialists, that my eyes are very much on that problem. And I'm sure there's other problems that are very, very important too. I spend a lot of time on that issue because we're all consumers and we all see it. You know, when you need to find, whether it's people with cancer, you need to find the right specialist. It is brutally challenging. You know, when a closest friend's dying of a cancer, got to try and get him to the right oncologist, and he can't do that. No one could do that until somebody knows somebody that can get him into that person. And it's just, but that's not scalable. That's not scalable that somebody ever knows somebody that can get him into the right person for the right thing. We need to have enough. I mean, you talk about shortages in rural areas, not enough doctors, nurses, allied health practitioners. Yes, more and more of our physicians have chosen to move to the top 10 metro areas in the country, but we don't have enough supply to fill out all these other areas that need help. So I view it as a really daunting problem that's staring us right in the face. I know there are other issues as well, but I do spend a lot of time on that issue because we all see it. We all see it. You know, if you need someone, a neurologist, good luck. And in so many specialties.
This viewer wants to know, many medical students and physicians are unsure where RVUs or Medicare reimbursement is moving toward, bundle payments, value-based reimbursements, etc. Could you provide more insight on how reimbursement is going to look like in the next 10 years for future physicians?
Yeah, it's a great question. And I don't know. I know the reality of it is the shortages of physicians are going to leave physicians in many places able to make a nice living regardless, because we're just a supply and demand issue. But right now you have physicians in many parts of the country that will opt out of Medicare or Medicaid and be able to go concierge, or be able to go payment only, third-party payment only. Medicare would like to move everything towards value-based care. They've got a goal that everything's quote unquote value-based care by the time 2030. The reality is, it's in my view, value-based care means everything, single thing under the sun. The dentist who asked the question in pediatric dentistry might be on fee for service, but when she sees her patient or he sees the patient, she or he expects they're going to provide the right value to the patient in the right time frame, and that may be under a fee for service system. This idea that we can capitate everything and turn it to fee for service is or be better than fee for service is sort of, in my view, sort of a joke. What it means is the people that get the capitation are often very aggressive about denying care or making it very hard to get care. So I don't know where it's going, but I know we're going to have a horrible shortage of doctors. So whoever you are as a physician should be able to make a good living. Like I can't assure you it's going to keep on being free for service, but I also can assure you there's going to be horrible shortages. You might have to go someplace you don't want to go to make the living you want to make. Like now there's not shortages in some metro areas, but there's horrible shortages in other metro areas. And so, there may be some flexibility in where you have to go, but you'll be able to make a nice living. I think somebody's on mute.
My apology.
There you go. Thank you.
Many of us agree on the need to modernize and streamline medical education. In today's world, rote memorization and regurgitation of that information to pass required board exams makes it difficult to move from memorization to current real-time knowledge acquisition through tools like AI and other data analytics tools to provide precision medicine. How would you propose we aligned accrediting organizations and standardized testing organizations to move medicine forward?
Yeah, no, I don't think it's the standardized testing organizations that are the problem. Well, that's a people like to demonize that. I think it's you need people in the leadership in medicine trying to figure out a better way to do this, because somebody who just said that hit it exactly right. We're relying on a system built before the internet on rote memorization and lots of other stuff. And I think it's the medical intelligence establishment, like all the education establishments, it's hard to change. And there's also not so much amongst physicians, there's a guild system in place as well, where people are not that motivated to change and add lots of new supply until they have to, until it's boiling and we don't have enough doctors. And I think we're getting there, but you have some systems trying to quicken things up and figure them out, but not enough energy placed on that problem.
I think they figured out how to change the system or the way we do math for kids. I think we can do the same for medical care. This viewer says, for the underlying lobby groups influencing the real decision-making, such as the American Hospital Association, pharma, insurance, AMA, how can we as students respect their motivations and financial incentives, but still lobby or advocate to push the needle of progress?
Yeah, I think it's a great question. I would, oh my goodness, and everybody's got their own biases. I think the AHA overall does as good a job as they could do. I think they've got just tremendous leadership today. I think they're trying to do the right thing. My own perspective, and if anything, COVID taught us we totally rely on our health systems as a safety nets for our country, notwithstanding everything else. So I don't. Oh my God, the AHA may be powerful. I don't put them exactly in the same spot as everybody else. The AMA I put as a close second to the AHA, and both those organizations have had horrible political influences over the last 50 years. I do think both of them, the AHA specifically, is just as good as they come today in trying to do the right thing versus the wrong thing. I just that's my own perspective. The health insurance lobby, I won't even talk about because I don't want to get sued today, and we know all these people and stuff like that. It just is, I think it's a really challenging spot in terms of the insurance industry. This thing with Medicare Advantage is a travesty. Excuse one of the dogs in the background here if people hear that barking. It's whenever I start talking about Medicare Advantage and the insurance companies, the dog starts to bark. I think what's happened here is the insurance companies, Medicare Advantage is the most obscene piece of justice I've seen. And we've turned Medicare into now 55% Medicare Advantage. And from all I could tell, we've added another layer of cost on top of it, and it's costing the government more. It just is, and it's taken away choice. It's exactly the opposite of what we really want to do for our consumers. So I don't know. I mean, I don't know what the individual patient. It is so hard to do anything. To come back to the question again, it is so hard to do anything when you're playing against people that have just huge, huge pockets. You know what you say about politicians? They'll meet with you if you're a constituent. They'll listen to you if you're giving money, and it is what it is. It takes an incredible amount. They're in business like everybody else is in business. Especially the Congress people have to run every 2 years to get reelected. So they're constantly fundraising. They've got to be conscious of they can't get too sideways with the regular constituents, but they also got to be comfortable with those that are providing money and economic support to their candidacies. And some of those lobbying organizations are really strong. It's a very, very hard question.
I want to switch gears here and ask you about
Thank you, by the way.
You're welcome. I want to ask you about one of the biggest threats facing healthcare, and that's cybersecurity. Considering, Becker's covered the Change healthcare breach, and we're seeing this every single day. Where do you see this going, and what changes in your mind need to be made? Because we know how valuable healthcare information is on the dark web, and hospitals are being targeted daily. And that's our information. And now,
it's not only daily, they're being targeted 24/7 every moment. And the actors, it's an arms race. The actors are becoming more and more sophisticated. The actors aren't, some kid in a high school basement or some basement. They're state actors. They're organized crime. It's organized crime around this. I got a call from somebody the other day saying, your gas is going to be turned off at your house unless you, I shouldn't have picked up the phone, unless you, give us money to pay the payment within 20 minutes because, ComEd, your local gas company, is turning off your electricity or gas, whatever it was. And it wasn't, it was exactly the sophisticated kind of pitch that you almost want to give the person your number because you're scared that you're going to turn off my electricity and gas and my wife's going to kill me, and so you almost believe it. But the state actors in the organized crime around cyber are so brutal. And with AI, it's going to get worse. You're in an arms race where they're working to get through to your system, to hold you up, to ransomware you, to get you back online. Aside from all the consumer use of all that data and information, it's a brutal game. Health systems, a lot of it still comes back to constant improving technology and constantly improving people's behaviors. We're all, I went to Harvard. People don't stay on a call for 40 minutes and not say that at least once. So I apologize for that, telling you I went to Harvard. But I went to Harvard, and somebody calls me on the phone and says, "We're turning off your electricity." And I'm like, "Oh my God, I better give them my credit card." And I held off, but it's hard. And they're gonna get, and it's both human and it's technology, and it's a constant war. And every system is facing it. Every system is trying to figure out how to be somewhat redundant so care doesn't get shut off when the health system gets shut off. A set of emergency providers got shut down in Texas not that long ago. The emergency systems, the ambulance systems, stuff like that. And it's life or death. It's life or death. They got shut down by a cyber attack, and it's life or death because you can't get people to where they need for care. And of course, we're so reliant on the technology today. I don't think there's a great answer. I think it's going to be a constant. It's going to be a never-ending fight to try and keep up with the cyber criminals. I think it's just going to be never-ending. I don't think there's any pat answer. There's, people do a great job, some systems, of tabletop exercises. What are we going to do if this happens? And I think those are very important. And people talk about redundancy. Redundancy is very, very expensive. And some of your redundancy, the cyber criminals are getting both. So it's constantly working at what are we going to do if it happens and trying to prevent it. And it's human and it's technology, and there's no easy answer. It's going to be an ongoing fight for the rest of our lives.
You talked about, you mentioned, with AI, it's going to get worse. What are the other key factors AI is going to have an impact on, and where do you see things going in the next 5 years?
Yeah, no, it's a great question. And we're already seeing, and AI is a different evolution of automating things and automating things. You're seeing obviously huge improvements in some areas on the administrative side of care where artificial intelligence is able to make it easier to deal with revenue cycle and some other areas. On the clinical side, it's improving. The great question on the supply demand issue is when does AI become not just a supplement to providers? Even you could see that now where it's a great supplement to PAs to practice close to the top of their license and be able to do so many things that primary care physicians can do. There are different specialties where at some point GI, most gastroenterologists doing colonoscopies, and again, there's a shortage of gastroenterologists, as screening becomes so important, they're using AI tools to better spot polyps and everything else, but it's a supplement, not a replacement. The issue will be at what point does our supply should become so bad that we find ways to use AI and intelligence to replace the physician versus supplement the physician. That's the 10x jump versus the 2x jump. And I think we're probably still a long way away from that. I mean, but it's really challenging. I mean, if you want brain surgery wherever you are, there's not enough brain surgeons. Is there a time at which a computer and a robot could do it? I just don't know. I don't know when that. I mean, at some point, I assume yes, but not for a long time. I think so many things are supplemental versus people talk about 2x versus 10x. Some of the things we're doing now are 2x. Meaning they really help us leverage talent. Radiology is a great example of this, is why we talk about trust but verify. Radiology was the first area that telehealth became the most important use case for, because you just couldn't get radiologists in small towns, rural communities, and you needed teleradiology. Now, notwithstanding that, we are short radiologists every place, notwithstanding the reliance on technology. So I think it's going to be AI plus people. I don't know, and all of us are consumers. It's one of the beauties of healthcare. I'm in the hospital. I feel much better if there's staff on that floor. I just feel much more safe, much more comfortable, notwithstanding all the computers, all the technology in the system. People still feel very importantly cared for by people, but we need enough of them. So I think it's AI plus.
Another issue that is, having significant impact is the consolidation of healthcare systems, of hospital systems, selling off buildings, getting smaller, if you will, or absorbing others. From your perspective, how big of an issue is that, and why should medical students pay critical attention to that issue?
Yeah, no, I think it's a great question. I don't know what the answer is. What happens is systems have to be large enough to be less fragile. There's a ton of studies on this where, there's two pieces of this. From a position themselves versus payers, health systems have to be large enough that's hard for payers and patients to go around the health system. So that's just a pure power between the payers and the systems. But far more than that, systems have to be large enough to be not fragile, to be able to invest in systems, to be able to invest in technology, to be able to hire physicians, to be able to hire nurses and so forth. It's very hard for a small hospital, to be able to put money into things like larger systems can. It's just a very, very hard situation. And it's why there's studies that show small hospitals close and end up bankrupt far more often than large systems. Not that it doesn't happen in large systems, but large systems often aren't as fragile to some of these things. So I don't know. I think you're going to see continued consolidation. There's a lot of mid-sized systems that do really well, that do really well because they're still able to really deal with a mission in a region, but they're not so big that they're so institutional. But I don't think there's a way around more consolidation. I just don't think there's a way around it. I think you might be on mute again.
Yeah, sorry. we're gonna wrap it up with one more question, and this is a two-pronged question from Varun, who's been waiting patiently for this. So two things. Varun is a subscriber to Becker's Hospital Review and is curious to know, how do you and Becker's decide which topics to prioritize, and how do you classify information? And before you answer that, there, for medical students or graduate master students who are interested in helping improve the healthcare systems, is there a way they can be involved in Becker's Hospital Review?
Sure. So I'll answer the second question first. We're always thrilled to have graduate students, medical students, for sure, come to our meetings. If you email me, Scott Becker, I'll make sure you get a free pass if you're a medical student or a graduate student in medicine to our meetings. Don't, sbecker at beckershealthcare.com. My text, find me on LinkedIn, text 773-766-5322. You could find me and we'll get you a free pass to our meetings. In terms of deeper involvement, you just have to talk to our editorial staff and figure out where and how and stuff like that. But always happy to also feature med students and grad students on our podcast too, as a way to hear what they're thinking and amplify the rest. So that's one. What we choose to cover. Our goal originally in Becker's Healthcare, it goes back a long time ago. I started the company something like 30 plus years ago, and it's evolved over the years. We very much rely on what we call short form journalism. We're trying to give people a sense of what's going on in different areas. We're not trying to do deep consultative work. So years ago, I used to write deep strategy pieces, and this goes to the question, and almost nobody would read those pieces. I thought they were brilliant. No one would read them. What people want is to know, to get a sense of what's going on. Are systems doing better, worse? Where are they investing? And what are they doing? Are they putting more money into this specialty, that specialty? Are they laying off people? Are they not laying off people? What's sort of going on? What's a quick sense of what's going on in the field, so that people they're not doing, we don't pride ourselves on being a deep, long form. We're not writing 2,000 word pieces. It's just not what we do. Now, what do we cover? That's a great question. So much of it is driven by metrics that we look at. We look at what are people reading? What are they not reading? All of our journalists, and we have 30 full-time writers and journalists and really smart people, really good people. They get stats constantly on what's read and what's not read. I'm a huge believer in managing loosely versus tightly. And so it's really our journalist job to see what's being read and not read and do more of what's being read. And that doesn't mean they can't explore their topics regularly. I mean, we have this concept of core and explore. So you understand your core of what readers want to read. If you're a journalist that nobody reads, you're not really a journalist. And we say that jokingly, but but the idea is you need to write what people are interested in and make sure it's also intelligently done. And so it's constantly focusing on what's read, what are people interested in, and then some exploring and experimenting. And we're constantly pivoting and learning new areas. But the core is we spend a lot of time on what do people find interesting? Why do they come to us? Why do they read us? So I hope I answered the question, but on those two questions, what do we focus on? We focus on what, that intersection, that Venn diagram of what our folks want to write on, but what people want to read and are interested in. We moved a long time ago to short form journalism, and we could tell you so many stories on, we'd hire writers that thought they were the next George Will and could write one column every 2 weeks. We're like, that just doesn't work in our world. We really like it, but we can't do that,
I
But I love the
appreciate it.
question. And no, thank you. And Varun, thank you for reading. Thank you all for reading. And I hope oh my God, I'm a huge fan of the dental profession. I didn't mean to offend our pediatric dentist. I am so sorry, but I do. It's a metaphor for everything we see, and all of us can understand it because we're all consumers of these services. So thank you so much. Thank you.
Scott, thank you. All right, I'm going to hand it back over to President Langell.
Thank you. Scott, thank you for an absolutely incredible presentation. Your enthusiasm and your passion are palpable. Really thrilled with the amazing work you do. Monica, thank you for the expert moderation as always. You certainly make Vitals worth watching for every one of our viewers. Ladies and gentlemen, please join us next time for Vitals on Thursday, November 7th, when we'll hear from Patricia DePompey, President of University Hospitals, Rainbow Babies and Children's, and McDonald Women's Hospitals, and Rainbow Babies and Children's Foundation Chair in Leadership in Innovation. Until next time, stay active and stay engaged, because it is you who will make a difference in our nation's healthcare.
This is VITALS, Visionary Health Leadership in Action.